OK，然后下一位讲者呢是来自德国 Wunstorf 血管超声和 CHIVA 手术中心主任 Erika Mendoza 教授，他是德国静脉病学会秘书长、国际静脉病学联盟委员。他从1997年来就在德国开设了一家静脉病工作室，主要实施保留大隐静脉的静脉曲张治疗。So next speaker is Professor Erika Mendoza. She is the director of Wunstorf Vascular Ultrasound and CHIVA Surgery Center in Germany, secretary of the German Society of Phlebology, and a member of the UIP Education Committee. Since 1997, she has established a vein clinic in Wunstorf and performing CHIVA. So her speech title is Allowing CHIVA for Starters, What is Needed to Start, and Which Essential Cases Will Provide Good Results Immediately. 我们用中文讲就是 CHIVA 的初体验，教大家如何轻松上手、立即见效的关键之道。
Dear Sophie, dear colleagues there in Shanghai, thank you for organizing this, as always, outstanding meeting, and thank you for letting me be a part of it, even though from the distance. You invited me to talk about allowing CHIVA for starters, tricks, and good cases, and here we go. I have no conflict of interest with this presentation. So CHIVA is as easy as first understanding how to investigate a patient with ultrasound. This is a preliminary thing everybody is needing to be able to. And then you have to find out the feeding source for the saphenous vein and the draining path for the saphenous reflux. So the feeding source can be from the deep vein directly via the terminal valve or a perforating vein, or indirectly via tributaries feeding the great saphenous vein, either from the pelvic system or from any perforating vein on the thigh or calf, filling a tributary and then filling the saphenous vein. And the same, the drainage paths can be directly via a perforating vein or via a tributary, which then drains into a perforating vein. This is the simple presentation. So let us have a look at the reflux sources, which can be from the deep vein, as we told. This can be the saphenofemoral junction. This is a reflux coming out of the common femoral vein and going inside the great saphenous vein directly in the groin, or like here, a perforator at the medial thigh, which is feeding, you see it here in the diastole, you have a long-lasting reflux into the great saphenous vein. You measure this at the level of the fascia, and this would be a refluxive great saphenous vein filled by a perforating vein. So then you can have the reflux sources not directly from the deep vein, which might be most often a tributary of the groin. This means that the terminal valve you will find here is competent. In systole, you have an anterograde flow towards the deep vein and already a reflux in the tributary. And in diastole, here you see the competent terminal valve and the reflux coming from the tributary of the groin and going inside the great saphenous vein. We will see a better image later on. Or you have somewhere at the leg a perforating vein which feeds a tributary, and this tributary again comes back to feed the great saphenous vein, which then may drain directly or however. So this is the proximal reflux point. This is a competent saphenous vein. The saphenous vein is incompetent starting here, and this is the draining from the reflux into the great saphenous vein. And from this point to the distal, the great have a reflux from the deep vein into the great saphenous vein. You see it here in the longitudinal flow. You see the systole, everything goes upstairs, and then the reflux from the deep vein to the great saphenous vein. And this is an image of a competent terminal valve, systole, anterograde and diastole, not from the deep vein, competent terminal valve. You have the reflux from the tributary of the groin inside the great saphenous vein. And so here you have a natural barrier for the reflux from the deep vein. And this makes other therapy options possible, which is very, very interesting. Here, a cross-section of the groin, a patient with an incompetent terminal valve and a patient with a competent terminal valve, and the reflux from the epigastric vein in this case. So now let's have a look at the drainage paths. We have the possibility of have perforating veins, one or more than one. And this is a paratibial perforating vein. You have a measurement at the level of the fascia, and you see in the diastole, it is draining to the deep vein. So this is not an incompetent, but a draining perforator, which is dilated because it drains. Or you have a tributary that drains at the end the reflux from the great saphenous vein via a perforator to the deep vein. But the perforator, the dilated perforator, is not situated on the great saphenous vein, but on the tributary. To differentiate one from the other, you make the reflux elimination test. You compress the tributary with a finger. We will see this in a movie now, but just to explain, without compression, you have toe elevation, toe cessation, and you have large reflux. If you have a perforating vein on the great saphenous vein, you have a toe elevation, toe cessation with reflux. Also, if you close the tributary, because the tributary is not needed to keep the recirculation going. Yes, the great saphenous vein drains directly through the perforating vein, and even if you close the tributary, there will still be a recirculation. If you close the tributary and there is no perforating vein, here is one, here is no perforating vein on the great saphenous vein, and you close the tributary, as long as you keep it closed, there will be no recirculation in the great saphenous vein. It will start the moment you leave the thumb from the tributary, and this shows that there is no perforating vein draining the great saphenous vein. It is only a tributary draining it. To differentiate between a drainage without or with a perforating vein, you use the reflux elimination test. Firstly, you test the reflux in the great saphenous vein, just elevating the toe and lowering it and documenting a reflux curve. You see here the tributary. Then you do the same test, closing the tributary with a finger, and elevation and lowering the finger means between the elevation and the lowering of the finger, you have a segment without reflux. I will show you this again. Here you see the option in slow motion. I have closed digitally the tributary. I have my transducer on the great saphenous vein. I ask the patient to do a toe elevation. Here you see an anterograde flow in the great saphenous vein, and you see no reflux until, listen, until I lower the finger, there is no reflux in the great saphenous vein. This is how to differentiate between a tributary as drainage path, like this case, or a perforating vein. If there were a perforating vein on the great saphenous vein, the reflux would have been the same as the first one. This means anterograde flow, reflux independently of the compression of the tributary, as the drainage is through the perforator. So you have two different situations. You can't see from the outside when you look at the leg. You can't differentiate with the bare eye if it is like this with the drainage point on the great saphenous vein, or it is like, it's like this without a drainage point. Both have an incompetent terminal valve, a reflux through the great saphenous vein, one draining only through the tributary and one draining tributary and perforating vein. And this is the differentiation between shunt type 1 with perforator and shunt type 3, no perforator on the great saphenous vein, which is the most important concept when you start treating. And then you have, depending on the reflux of the if you have the reflux in the groin tributaries with the terminal valve competent, you have a shunt 4 if you have a perforator, or a shunt 5 if you have no perforating vein on the great saphenous vein. So let us see. We have shunt type 1, which is a reflux in the great saphenous vein and in the tributary. And the treatment is the interruption at this point and the interruption at the tributary point. And as a result, you will have a drainage from the tributaries, from the healthy physiological tributaries into the great saphenous vein, a deflux going down, and a drainage through the perforating vein, which is already there, enlarged on the saphenous vein, and then a drainage to the heart without a new recirculation. This is the principle in one of the most often seen recirculation with this shunt type 3. And what happens to the great saphenous vein after the proximal interruption? Here you see preoperatively a long-lasting reflux, and here you see it afterwards. You have an anterograde flow, a short just to close. And if you wait a little bit, then the tributaries will drain into the great saphenous vein, and you have a tiny flow downstairs to drain through the next perforating vein. In the shunt type 5, we have a competent terminal valve, a reflux from the tributary down the great saphenous vein, and then through a tributary, no perforating vein on the great saphenous vein. What happens in this type? If you just interrupt here at this level, flush ligation of the tributary at the level of the great saphenous vein, you will have an anterograde flow in 97% of the cases after 3 years, as demonstrated by Samboni in this group. This is a very interesting option because you keep reflux from the pelvic system stably draining through the competent terminal valve to the deep vein system, and an anterograde flow in the great saphenous vein. This is the most interesting and the most conservative way to treat the saphenous vein. In the shunt type 3, we have to think a little bit because we have sometimes this recirculation with the tributary, and it depends on the diameters and what you will gonna choose. So now, before we start talking about the treatment of the shunt type 3, which is the most complicated, just because you have to think a little bit about the different options, I just want to show you why you can't treat it like the shunt type 1. So this is shunt type 1 with a perforating vein. This is shunt type 3 without. Shunt type 1, we have agreed to treat at the groin, at the uppermost. So in the shunt type 1, we have decided to close the saphenofemoral junction and to close the tributary flash ligation at the saphenous vein. If we do this in the shunt type 3 patient, this part of the saphenous vein will not be drained like here through the perforating vein, and you can have postoperative pain, thrombosis of the great saphenous vein and spider veins following. So in the shunt type 3, in case of great diameters over 6 millimeters proximal thigh or 9 millimeters in the groin, and a long distance between the groin and the tributary, it is better to close the GSV at the junction and wait what will happen with the tributary. This is one example. This lady had a large diameter great saphenous vein. I closed the great saphenous vein in the groin 7 centimeters. Immediately after, I put her standing back again, and you see already a fantastic disappearance of the tributary. Here was the puncture for the laser ablation, and this one was the result 1 long month later, and she wasn't bothered by it. And most of the times, after some more months, they will disappear furtherly. This one was another lady with a very tiny GSV and a shunt type 3, and we closed just here, and 3 months later, 4 months later, the tributary was not longer visible and the great saphenous vein was antegrade. So this is also a good option. This guy has a real large varicose vein, and he came because he had itching and he had edema. And this is the diameter at the proximal thigh, 1 centimeter. And this is the reflux he had at the proximal thigh. I made a laser ablation of 7 centimeters from the below the terminal valves to drain, to allow the pelvic veins to drain to the deep vein. And this is after 6 months. You see the great saphenous vein has a reduced caliber, has a perfect flow. This is the clinic. So you see this reflux converted to this. And this is the clinical result. And this is the clinical result. You see from C4, C3, no more edema, no more skin discoloration, and a significant reduction in the diameter of the tributaries. And this is the flow curve. One last case is this one. He had a large saphenous vein reflux, shunt type 3, and we closed both saphenous vein proximal party 9 centimeters with laser. And 2 months later, you have this situation. This was part of a study where we made a tilt table investigation. And this one was a patient standing on the tilt table, recumbent. Then if you put him standing, the patient was on the tilt table. And when you put him standing, there was a ultra quick filling of both legs, the same as a ultra quick emptying. So he had no issues in the deep vein. And this was, of course, a large volume in these legs. And this was the working volume. This is the filled leg. This is the empty leg. And this was 2 months later. You had a far less working volume because there is no more circulation in the leg. And he had a completely normal, quick drainage and a completely normal refilling time when you put him standing back again. So this is just to show that with little touches, if you start doing CHIVA, you can do it with patients with large varicose veins, not saying that all the large ones are not good for CHIVA, like in Germany, this is always said from people that don't understand the problem or the technique and the strategy.
You give us some very detailed information on different strategy about different shunt. I think that will helpful for our clinical work.
Thank you for listening.
那个 Mendoza 女士呢，给了我们非常详细的 shunt 类型的策略，所以大家在这块有没有什么问题 ？Okay, we have some question from our audience, please.
我有一个问题，就是我们在工作的时候会遇到，就是大眼静脉上面，就是它有一个2P， 但是那个2P呢就非常的细，而且尤其仅有一个。那这种情况下，其实按照分析呢，就是属于橡体一。那有的时候我还是会担心它这一个很细的这个2P 点能不能，我会担心这个问题，就是能不能就是将大眼静脉的血引流回去，然后我会担心它会有血栓的这个问题，我不知道这个是如何去解决这个问题。
Okay, and the question is, the doctor said that he met some cases during his daily work. We can see re-entry veins on the trunk, but the perforator vein very tiny. So he is worried about whether the perforator vein can drainage the blood very effective. And he want to ask Mendoza, what will you do when you met this kind of situation? Thank you.
Thank you for this very interesting question, because this is one of the errors you do when you start. You have to, if you do this RET test and the draining perforator is very tiny, you will have a situation where there is a little reflux, and when you lower the finger, the reflux is again large. And if you see this, you should consider it like a shunt type 3, because the diameter of the perforating vein is not proportional to the reflux volume. So as another rule, you can say if the diameter of the refluxing vein is like a fourth only of the diameter of the refluxing saphenous vein. So you have a saphenous vein of 8 millimeters and the perforator draining but only 2 millimeters. This is not appropriate to be considered as a draining one. If you have 4 of them, of course, the sum of them will make it. But the best way to show if it is enough or not will be the reflux elimination test.
需要我翻译一下吧。那门多萨教授呢，就是说确实有这样的情况。那这个时候他要做一个指压实验，看看这个效率如何。那如果你会看到指压的时候反流停止了，或者变得特别的低频，但你松开的时候，它一下哗的又出来了，那这个时候可以判定它为不能够完全的充分的引流。它更倾向于这种情况呢，按上特3的原则处理。那这边也很有意思啊，他在讲课中提到了，对于这种情况，他其实做的是 laser， 就他会把上面那一部分给它关闭掉。那这样的话呢，它避免了术后血栓的可能，它只是2到3的 EP 点它留着，但它把主干关掉以后，实际上相当于2到3也是被关掉了，所以看到它的效果也是不错的。OK， Mendoza, please.
Yes, thank you. I want to comment on the fantastic presentation Claude has done before, because it is very, very important to use correct non-resorbable material when you do the crossotomy. And I just want to explain why I do it with laser. In Germany, the crossotomy is not reimbursed. And so people, I treat every people, not only the one with much money. And I found a way to do it another way with this short laser below. So I allow the drainage of the pelvic veins and do the closure between the tributaries in the groin and the posterior arch vein, which comes in just below the junction. And this is how I solved the problem that I had no reimbursement for the classical CHIVA. This, for me, it is very important. I'm not propagging to do it with laser, but I'm saying this is an option. And if you have a good surgeon doing the crossotomy like Claude described it, this is the best way of going ahead.
Okay, thank you. And Mendoza 女士呢就告诉我们说，她在德国呢，因为一些付费，还有她的这个执照的问题，她没有办法做非常经典的 CHIVA， 就是我们现在做的那种点式的关闭，所以她才选择了用短段的 laser 去实现 CHIVA 的这样一套理论。Okay, thank you, Mendoza. Claude, please.
Yes, just you hear me? No, just to tell you that the reflex test is, as Erika showed you, is very good, but sometimes it doesn't work because the aspiration is not made by the calf, but by the thigh. In that case, I used to use a Valsalva test, and Valsalva test works every time and show you better the reentry you can have. And that's, and on the other hand, the caliber of the reentry perforator, even if it is very thin, I use it because with time it enlarges. It is possible to enlarge. That's true that at the beginning it's not that good, but with time it enlarges. So for me at the moment, I have any perforator, thin or large, I use it and I disconnect the shunt.
OK， 那 Claude 先生补充呢，他说，其实在他的理念当中啊，他认为 perforator vein 都是很宝贵的，我们都是还是要值得重视的，不管它现在是细小还是比较粗大。因为呢，在血流动力学的这个纠正理论之后，它其实是有机会能够充当一个完全充分的引流路径的，所以这是 Claude 教授的补充。OK， any question, please？ 有没有话筒？嫣红有没有话筒？ 啊，那你就声音大一点吧。We have another
你好
question from our audience.
我是中山七院的梁医生，然后刚才那位吕教授他做的方法其实跟我目前做的方法有点类似，他用的是激光，我用的是微波，然后我也想像他一样实现一些短距离的消融，来实现类似结扎的方法。我想问的问题就是你一般会挑选多粗的血管来用这种方法，而不把它转接到外科去做结扎。另外你一般会烧短段是有多长呢？你一般会选择多长的路径来进行消融？然后另外一个问题就是有没有遇到烧完以后过一段时间再通的情况？如果再通，你是还再烧一次呢，还是在那里打硬化剂呢，还是转到外科重新结扎呢？就主要这两个问题。
Okay, and here's a question for Mendoza, and his question is he used a microwave just like you did, and he used microwave to close the trunk of the GSV, and he wanted to know is there some kind of 标准 will you he means do you have some require of the diameter of the trunk? For example, if the trunk diameter is over 8 milliliter and you will not use laser, you will suggest the patient to accept open surgery. And he also want to know the recurrence rate of your laser CHIVA treatment. And still he wants to know how long will you use the laser to close the trunk? How long the segmental, I mean. Thank you.
Okay, thank you for the question. I don't have any experience with microwave, but I use as the length of the closure is between 5 and 10 centimeters. I use 10 centimeters only in cases where the diameter of the great saphenous vein in the groin is more than 15 millimeters. And with this, I'm telling you that I'm using large diameters. I have no limitation because if you put properly the tumescence, you reduce the diameter of the veins. This is the question one. So I have no limitation, and I think that yes, the failure in closing the vein is higher when you have a large diameter. This is true, but with the years, the skill, you learn to reduce this problem by using more tumescence, compressing, and more energy at that place. And if I have a thin vein like 5, 6, 7 millimeters, I use 5 centimeters. And if I have a large one, I use the length I use is 10. And this is empiric because I didn't study the length, but I compared 100 patients surgical crossectomy, not crossotomy, because I have nobody doing crossectomy, 100 crossectomies versus 100 laser ablations. And in the follow-up of 1 year, there was no difference in the diameter reduction of the saphenous vein. They had, in both groups, there were no recurrence and no failures of the closure. I have failures of closure really when the veins are like 2 centimeters in the groin and the person is taking anticoagulants and so on. But this one you can discuss with the patient earlier and send them to surgery, but I very seldom send them to surgery because I'm having a classical crossectomy and not a crossotomy. And I think I'm sparing more of the drainage paths when I do this laser below the terminal valve.
那个门多萨教授说呢，他自己是没有直径限制的，因为他可以通过挤压和提高操作功率来增加这个闭合率。然后长度呢一般是10个公分。Here is another question for Mendoza. If you met someone, they got a recanalization after laser, what will you do with them?
Yes, I have seldom, but I have recanalization. I had just one case I have both laser and radio frequency. I use the other thermal source. And in this one patient, he was on warfarin, and he had a diameter before the first operation of 2.5, and he had an ulceration. The ulceration closed. The diameter went down to 12 millimeters. I redid it. The diameter went down to 8 because the vein was like sclerosed and he had no complaints, and he didn't want to have anything further. Otherwise, I would have sent him to surgery. But in all the other cases, I look back to 5 other cases in the last 10 years that recanalized or didn't close. And I with the second attempt with the hot heat application, they were all closed. So I redo the heat application.
Yes, you mean you redo the laser, right?
Yes, okay. I redo it because I just do it in a short segment, and I can go there with the laser probe very easily.
Okay, thank you. Okay, if there is no other question and comments, and we will start our third lecture in this session.